So I know before, maybe before some of you guys got in, one of the students asked about a certificate of attendance, and I got a couple emails from last week as well. If you would just shoot me an email so I can kind of save it for anyone that needs proof of attendance or looking for proof of attendance for a portfolio or for a school, just email me, and I'm keeping a folder so I know who to get them to once we kind of get them made and figured out how to work that. I'll throw my email in the chat thing. All right, well, I think we will get started, guys. Thank you guys for joining. This is our third so far. It's our second knee series. And so we've decided that we're going to stick, instead of jumping around. First week we did a shoulder and last week we did knee. We decided we would kind of spend a couple of weeks doing the same joint and then kind of move throughout the body. So we're going to do, last week we did knee OA and mobility deficits. And today we will be doing more of movement coordination deficits. So still sticking at the knee, but mostly we'll be focusing on patellofemoral pain as our topic. All right, so if I pull up, you guys should be able to see the PhysioU app page. All right, if for some reason you guys can't see it, put it in the chat box so I know to change screens. Okay. All right, and we'll go down clinical pattern recognition and knee. All right, so if we're thinking of a pain pattern, right, and we're thinking of patellofemoral pain, right, we're going to think of as that anterior knee pain. Right? What would be some of the other diagnoses that if a patient walked into the clinic and was talking about anterior knee pain and they're kind of pointing there, what other diagnosis would you want to hypothesize about or think about? Go ahead and shoot it in the chat box about some other options. Good. So someone wrote OA, osteoarthritis. Another person wrote instability, patellar tendonitis, meniscus. Yeah, great. Bursitis. Good. Yeah, so lots of differential diagnoses when someone comes in with this kind of vague anterior knee pain, right? For the one that says arthritis, we think arthritis, what would be one of maybe the big giveaways between ruling that in or out, just based on maybe even looking at the chart or the patient walking in the room? Yeah, some morning stiffness. How about demographic wise? Think about demographics. What type of demographics does someone might have OA versus someone might have? Good. Age. Perfect. All right. So if someone's 24 versus someone's 64, automatically OA might go up or down significantly. Good. Okay. So if we click on, good, anterior knee pain, all right, patellofemoral, patellar tendonitis, great, knee OA, you guys kind of nailed all those. You guys even put in a lot of the much less common ones, right? Someone put in, I think, bursitis, meniscus, definitely a common one, can cause anterior knee pain. We think of that more as medial or lateral joint line pain because it's one or the other, but definitely in the clinic, we see it as anterior knee pain as well. How about red flags? What do you guys think about red flags? For someone with anterior knee pain, what do you think would be something that should be in the back of our mind? So I see numbness and tingling, rule out cancer. Yep. Nice. Patella fracture. Good job, Jordan. Yep. What would be one of the pieces of information we'd probably gather in the subjective or the patient interview that would maybe lead us to one of those different red flags? Right. So the person that let's say the person that put cancer, right? Much less common, right? Most of the time, if we're going to have some type of bone cancer, it's going to be between the shoulders and the hips, the spine being the most common, right? That's where things will metastasize to. but it's not unheard of, right, to have some type of sarcoma or something towards the knee area. But what would we expect if it is cancer? What would we expect maybe to hear from that patient in the interview? Night pain, family history, sudden loss of weight. Yep, good. Not necessarily the bowel and bladder changes if we're thinking cancer. More cauda equina for that. Non-mechanical pain, yep. But also probably painful with every weight-bearing step. Good. Nice thing is very, very, very minimal percentage of people that are going to have some type of knee cancer type. So if we go to a fracture, right, which is probably the most common red flag, would be a fracture. What is going to be the telltale sign of that? Right? What would make us think that someone might have a fracture? Perfect. Trauma, nice. Intense localized pain, right? Can you guys recall there's a special set of rules that kind of help us with ruling in or out a patellar fracture or a fracture around the knee? Can anybody think about what those are? It'll probably be on your boards test. Good. So Ottawa knee rules or the Pittsburgh knee rules. Yeah, exactly. So looking at, right, was there some type of trauma, and the type of trauma changes based on their age. So the older they are, the less traumatic it has to be, right? And then they talk about the inability to walk 4 steps. So they can't weight bear in the emergency room. And then bony tenderness, whether that's the patella, the fibular head. Yeah, you're looking at, is it severe, intense tenderness? So good job, guys. And so they don't happen very often, but we want to make sure that we can identify red flags if needed. So if we click on patellofemoral pain, so let's click on the one we're going to go down. Okay. Right. Prevalence, you guys already talked about what is a big distinguisher between that and the OA, right, is age, right? How about, can you think of another big, something else in the subjective or even in the chart that might distinguish someone from, yeah, this person probably has knee OA without, or I'm sorry, this person probably has patellofemoral without me having to really even test anything? What would put that high on my radar? I think we're thinking subjective. So patient interview, we haven't done any objective tests yet.
Anything that I have, and they
Okay.
back to me. I mean, really, they do. So that helps a lot. The communication has changed so much from when medicine was little to now.
Yes.
And sharing of information.
All right, I'm just going to mute a couple of you guys.
Much faster than.
There we go. Okay, good. Good. Yes, so somebody put sex. So yes, so definitely more common in females and males. And then you guys, a lot of you started throwing out AGS. So stairs, good. Prolonged sitting, yep, so they call it the moviegoer side. All right. Yeah, athletes. So we already started to think about someone who's active, a lot of weight-bearing activities. They're younger. Female tend to be more than male, but also males can have it. Good. So based on just that information alone, from a chart review probably, we're already starting to think this is a pretty high on our list. Okay. What would be, right? So now if we think about physical exam, what would be some of the key tests that you guys would want to test to rule in?
Card sign, eccentric step test, step down test, squat.
Perfect. Yep, all of those. So the nice thing is some of those that you read out were functional tests, right? So we get to look at how they move, and technically they shouldn't be painful in the average person, right? But someone with this diagnosis, it may be painful. And then some of the other tests you threw out were more pain provocation tests, right? Where they're laying on the table and we're trying to rule in a certain tissue source, right? And those are kind of both when we talk about clinical findings for someone with patellofemoral, those are how you diagnose it. You have some very clear tests that look at tissue pathology, like can we irritate and stress this test? But then you also want to look at it functionally to be like, oh, what are they doing that leads to this test? And the eccentric step down test is actually a test that has a sensitivity and a specificity for patellofemoral. So yes, it kind of fits into both of those. Hey, it's for a diagnosis, but it's actually for a movement as well. So we kind of like that test, right? How about else? What else would be some other tests you guys want to look at? So you guys talked about step down, you talked about Clark's and grind. Mcconnell's good. Someone, okay, so someone looks at maybe an x-ray, yep. The J sign, okay, so looking at when you contract the quadriceps, does the patella glide like it should? Good, nice, okay. Right, and then Kevin started looking at more impairments. So now instead of looking at things that maybe cause knee pain, start looking at impairments that lead to the way they're moving. Good, okay. So let's see if we go to, all right, so key findings, physical exam, right? So remember, with any time someone comes in with knee pain, part of our exam is looking at that joint. So if someone has shoulder pain, we're gonna look at shoulder active range. If someone has low back pain, we're gonna look at lumbar active range. So we always wanna make sure that we don't just go straight to all these special tests, but we still put the time in to look at that specific joint. So we are gonna do a knee mobility exam. So you look at active range, passive range, and someone that has patellofemoral pain, if we're looking at flexion, extension, and we're looking at overpressures, right? What do you guys think about of those? Do you think that you expect those to be painful, not painful, limited, not limited? What are your guys' thoughts on active range of motion in the knee?
We have clicking sounds, pain with flexion more than 90 degrees.
Good. And I would say, right, clinically, right, well, actually, let me talk research-wise. In the guidelines, they say there really shouldn't be a big lack of range because this doesn't really involve the tibial femoral joint. If we're thinking patellofemoral joint, there shouldn't be a big lack of range when we look at knee flexion extension because that is tibial femoral mostly. Clinically, I would say I still see patients that have pain because the patella still has to move, right? When we extend the knee, the patella needs to glide. When we flex the knee, the patella needs to glide. And so if there is some type of gliding issue, I would say clinically I do see pain with it, but we may not see like a big lack of range. Right? They may not be very limited. They may have full knee extension, possibly hyperextension, and be totally fine with it because we're thinking of it more as when we check active and passive range is more of a tibial femoral problem. Now, think of someone who we may be mobilizing the kneecap a lot to improve range, right? Think of all of our post-op patients that they talk about, oh, you should be mobilizing the patella to improve range. So I don't want you guys to walk out of here thinking, oh, the kneecap isn't involved with mobility. It is very much so. But if we think patellofemoral, it's often patella being stressed at certain angles. So you may, as you flex the knee, there may be a point where it hurts, but it's not necessarily like a stiff end feel where it can't go, and it's a mobility problem of the tibial femoral joint. Right? So we do want to look at it though, because it tells us, are we on the right track? Is this a knee issue? Or like you guys said, is there some bigger problem going on, maybe from the back, maybe a red flag, right? Another key impairment is we probably want to look at patellar mobility, right? We want to look, how does the patella move? How does it glide, right? Superior, inferior, medial, lateral, right? You guys threw out Clark's sign, right? Right, so yeah, so kind of pushing down just superior to the patella, have them contract their quads. Show of hands, people that don't have patellofemoral, how many of this is painful on you when you guys tested this in school, right? I don't have patellofemoral, but I get apprehensive anytime someone tries to practice this on me because I'm like, oh man, this does not feel good. So a better one than kind of Clark's sign for maybe a higher irritable patient would be a grind test, right? Where you're pushing into patella and you're compressing it, which shouldn't bother people, right? It's normally non-painful, right? Good. Right, so those would be our key findings, right? So there's not too many tests to rule in that should make the patella hurt with when we rule in patellofemoral, right? We look at patella, we look at some special tests, we look at the knee in general. More of our exam, so that's kind of the easy part. It's like, oh yeah, you know what? I think this person has patellofemoral. Let me rule it in by pushing on the patella. It's painful. More of our exam is going to be looking at how people move, because we talked about that eccentric step test. That is an actual test to rule in patellofemoral. Right? But let's say you pushed on Clark's test, you pushed on your grind test, and both of those were negative. So you're thinking, well, it's not patellofemoral, right? What would be some other tests that you'd want to do to rule in some of those hypotheses you guys talked about? What would be a test we haven't talked about yet?
Aples.
Good. Okay. So what are we trying to rule in or rule out with Aples? Like what tissue are we trying to? Meniscus. Good. Meniscus. All right. So if we're thinking patellofemoral, we expect that to be negative, right? All right. Someone wrote McMurray's to rule out. Okay. Good. Again, what are we doing with McMurray's? What are we trying to rule out?
It's meniscus again.
Meniscus again. Good. Good. Does anybody have any issue with, think clinically, someone with patellofemoral pain, and you do a McMurray's test on them, or maybe you do like a Thessley's test on them, another meniscus test. What are some of the issues you might run across?
They're highly irritable.
Okay, highly irritable. Yep. And then if we think of someone with patellofemoral, anytime we put them into a loaded knee flexion, maybe we wind the femur into internal rotation, that's probably going to bother someone with patellofemoral. That's kind of how you do Thessley's, right? Single limb squat, and then you rotate back and forth, right? There's a reason why Thessley's by itself isn't a great test just for meniscus, right? If it's positive, it means something in the knee hurts, right? It's kind of like 3-4 other tissues, not just one. So good. So yeah, so we want to rule out. So let's see, if we look at differential, right? Clinically, when I think of someone who has anterior knee pain, right, and I'm thinking patellofemoral and really the patella is negative, I start to think, well, let me move half an inch down, right? You start thinking patellar tendonitis, right? Younger, athletic, anterior knee pain, running, jumping, kind of fits the same demographic. Sex a little different, tends to be born males and females. But you kind of think like, oh, super ags, right? So we want to make sure that, hey, you know what else in an anterior knee do we need to rule out, right? And so patellar tendon, how do we rule in or rule out patellar tendon problems? And don't necessarily think movement fault. Now think about, you know, I want to implement this tissue. Oh, I'm sorry. So someone wrote resisted knee extension. Yep, definitely. Good. So if we're testing quad,
Palpation.
boom, good, a big one, palpation, right? Right. Tendons normally have a very high threshold to palpation. You should be able to push on a tendon pretty hard. But if it's something's irritated, something's inflamed, something's sensitive, right, you might be able to bring on pain there. Good. The resisted knee extension, right? So someone wrote kind of testing quad strength, right? Good. Is there a certain way that you would want to test that to make that test more sensitive? So let's say I put someone, they're in supine, I have them at 35 degrees of knee flexion, like I'm doing like a quad test on the table, right? And I MMT their quad, it's not painful. So are you thinking, no, they don't have patellar tendonitis, right? I tested their quad strength at 35 degrees, it was fine. Good, nice, good job, Kevin. Yeah, you want to perform it at various ranges. The more that you flex the knee, right, the more that you are stretching that tendon, meaning the threshold is lower. So if I test someone's quad at 60 degrees and it's negative, but I'm thinking, you know what, this guy, it sounds like tendonitis, right? I want to make sure it matches. I may flex that knee to 90, 100 degrees and have them contract it there. And then that should hurt. Someone who's really low irritability. So I have a guy who doesn't really feel it until his third game of basketball. So he has to play basketball for over 45 minutes for him to start to feel this knee pain. And then it hurts afterwards for a good hour, 2 hours. But in the moment, nothing, right? I can make him jump on one leg 10 times. He's fine. Contracting his quad at every single angle, right? It didn't really bother him. But if I did a bunch of resisted eccentric quad strength, so I just kind of had him fight, and we did like 3 in a row, then he would start to feel it. So you have this ability of different angles, but also we think of manual muscle tests as an isometric test most of the time, right? That's what we're taught for neurologic patients. Oh, it's isometric. But with orthopedic patients, realize we can switch that to a concentric, eccentric, knowing that tendons kind of are more irritated with concentric stuff. Good. Okay. And then infrapatellar fat pad, right? That kind of sits right underneath the tendon. So it's kind of hard to differentiate between that. Why is it important, do you think, to differentiate between this person has the patellar tendonitis or patellar tendinosis versus this person has the infrapatellar fat pad problem, a Hoffa's problem? Does it even matter? Okay, so Joanna, treatment approach. How is the treatment approach different? They both have anterior knee pain. They both hurts when they jump, when they run. Good. Nice. Yep. I think you guys pretty much nailed it on the head, right? The treatment for both of these is very different. If someone has a fat pad, you kind of think of that as like a bursitis almost. Early on, you want to shut them down, let it rest, ice NSAIDs. Same thing with the tendonitis. Early on, you're going to treat that very similar. Whatever the driving cause is, let's shut it down, take 2 weeks off, right? Stuff like that. Now, the tendonitis, if it becomes a chronic thing where it's a tendinosis, you're right. We totally want to reload that tendon, right? You think of your EDU rep model, right? You educate them and you gradually load the tendon up, right? You start with eccentrics, very slow, and you build up weight, you build up speed, you build up angles. It's all about teaching the tendon to handle the load. Perfect. If it's a fat pad problem, most of the time it's going to be due to friction, right? Things rubbing. So it's more going to be like an alignment issue, or is it more of like a soft tissue restriction? So is the quad too stiff? Someone with a fat pad problem, we don't want to give them tons and tons of eccentric reps and tell them, hey, it's okay, it should hurt, that's normal, which is what we do with our tendinosis patients, right? All the research with tendinosis says it should be like a 3 to 4 out of 10 pain, and that's okay. If it doesn't hurt, what do? We add more reps or we add more weight to make it hurt a little bit. That's the gold standard for a tendinosis problem, not for a fat pad. So it is important to try to differentiate, even though it's hard because they both sit really close to each other, but trying to identify if it is the fat pad, a lot more conservative measures, a lot more maybe stretching, exercises based on alignment versus load for the tendinosis. Good. Okay, so let's go back to, so good job with the ruling out of the things. You guys talked about meniscus, we talked about patellar tendon, fat pad. We go back, good. Physical exam, good. So back to movement faults. We did key findings, right? There are 3 movement faults that research supports. There's other ones that kind of research isn't as strong, but if we think just research evidence-based, there's 3 faults that can drive patella to have more compression in the trochlear groove. And that's really what patellofemoral is, right? It's patella rubbing in the groove. So one of those would be femoral internal rotation, right? Another one would be excessive quad dominance, whether your knee is going too far past your toe in a squat or it's going too far backwards into hyperextension in standing. So it's where your knee isn't loaded in neutral. And then also, if we think below the knee, you have this midfoot pronation, right? If my midfoot is collapsing, it's going to drive the tibia into a rotation and then eventually the femur into rotation. So now you're loading this limb with things not aligned properly, right? So those would be the big 3 movement faults. So the question now is, how do you decide which one it is, right? We don't want to necessarily go around treating everybody for all 3 of these movement faults. How do you decide which one do you think might be the biggest player in your patient with patellofemoral pain? Good, test a squat. Perfect. So you have someone do a squat, right? It hurts, right? We expect it to kind of hurt with patellofemoral, right? What do we do next?
Test the squat, then make adjustments by Joanna.
Perfect. Yeah, and see if it changes, right? So if we think about if someone squats down and we see that their femur rotates in the internal rotation, Oops, sorry guys. Let me get rid of that. Somehow get rid of that. I'm gonna stop sharing for 1 sec. For some reason, my email popped up and it won't let me disappear it. Quit mail. There we go. All right, let me go back to share screen. All right, are we back? Can you guys see the screen again?
Yes, sir.
All right, sorry about that. All right, so if we click on squat, all right, and we watch them squat, and we see them dive into femoral internal rotation. I turn it on, right? See them squat. All right, we don't want to make those corrections right away. We want to see how she squats first, right? We don't want to kind of show them all of our answers. So we squat, how much does it hurt? Where do you feel it at? Is that your pain? All those kind of questions you've been taught. And yeah, let's make adjustments. So one adjustment would be like, you know what, just push out into my hands. So teach them to push out, see what happens, right? If that makes their pain go away or decreases their pain significantly, we're already thinking like, you know what, this person's gonna be pretty easy to treat, right? I'm able to make this adjustment. They're able to push out, they kind of get it. Let's say they push out and it doesn't really change their pain, or it doesn't change their internal rotation, right? When they push out, their leg still dives in and they get internal rotation, still hurts. What would be the next step? Is there a next step? Look at the pronation component, good. So we can either A, switch to a whole nother component. So someone says, look at the foot, but we could also say, you know what, how about if I manually, right? You weren't able to push your legs out enough to correct it. Well, how about if I manually take my hands and I correct it for you, right? So I'm gonna take your femur, I'm gonna rotate it externally a little bit, and I'm gonna hold it, I'll be your muscles for you, and then retest it and see what happens there. Does that change your pain, right? So we can look the same thing with a squat, right? We watch them squat. I'm sorry, step down, forgive me. Watch them step down. Ouch, it hurts, their knee dives in, right? Can we just cue them, right? Having them push out to the side, have them turn on some of their abductors, right? Give them a cue, tell them, hey, don't let your leg dive in, and have them recheck it. Good. See if that changes it. Now, if they can't change it, right, I'm going to be their muscles for them, right? I don't want to walk away thinking, oh, it's not a femoral rotation problem. Maybe they just aren't strong enough to control it on their own, right? So we can use the TheraBand, right? If we pull it across their body, we're giving them resistance into abduction, external rotation, correct? So we're kind of cueing them to turn those muscles on. So if they have the strength, that's fantastic, right? If they don't have the strength, we possibly might make it worse, right? We're pulling your leg into internal rotation. So then in that case, maybe we need to pull it to where actually the band helps them. So now we're going to pull it into external rotation, abduction. So now when they do a step down, their muscle doesn't have to work as hard because they can control it. So realize we can use TheraBands to add resistance, which makes the job harder, but it's better for cueing. Gives them something to think about, but also it could make it worse. So then we think, well, maybe we need to make it for assistance. Good. Good. So the idea is we want to look at some of these different tests. So we have some tests for some tests that we would do on 2 limbs, like a squat. A lot easier to change if it's on 2 limbs than 1. Then we have some things in single limb stance, like a single limb step down or a single limb squat. But then think about, let's say that, I think someone earlier said, how about the irritable patient that really, every time they squat, step, it hurts. You can't really control anything because everything's so painful, but you still see them diving in and their pain was a 7 on their squat. You corrected, it went to a 5. We don't really want them still doing squats with a 5 out of 10 pain, right? Yes, it's better. It helps guide you. So maybe we need to pick something non-weight bearing in the moment, right? And so here would be a test like a non-weight bearing where they're sitting and we're just watching them kick their leg out. Right? And if they have this femoral rotation movement fault, when they straighten their knee, right, we might see that it still rotates internally, right? So if you watch those red dots, they're turning inward as she kicks out. So we can train it here. we can train it in open chain, right? There's no weight on the knee, right? Hopefully there's no pain with it, but we can still train her to just keep her femur from rotating internally. Right? So if we think of this as our most common fault, this femoral internal rotation fault, right? How would we treat that? So we already talked about, okay, we would correct it. I think someone wrote something about using a mirror. That's fantastic. Giving them cues, tactile. But let's say they don't have the ability to control it, right? There's something that's not letting them fix it every single time. What would be the next step? What would we want to look at maybe on the table?
Manual muscle tests such as glute med.
MMTs, glute med strength. Perfect. Good. And I think the first 3 or 4 that I saw throw up were glute med, right? Let's not forget about glute max, right? Even though its primary job is extension, right? It's a very strong external rotator. Right? The glute max is a stronger external rotator than the glute med. So if someone's problem is internal rotation of the femur, it's rotating in, we're probably more likely to get more out of our glute max than our glute med. Now, if it's diving into adduction, you're right, the glute med is a better abductor than the glute max. So just kind of think about what movement fault do we see? Is it a combination of both? Is it more one versus the other? But yeah, so if we kind of go to physical exam, so associated impairments, right? I think a lot of you were talking about looking at muscle strength. Yep. So if we look at gluteal muscle strength, we want to look at glute med, right? Glute max, right? We can definitely look at, those would be our primary impairment tests because those would help control the femur, right? Good. And then I think, how about muscle length, right? We'd want to look at an Ober's test, possibly, right? You think about your TFL is a strong internal rotator. So if it is stiff, right, it may not let the femur externally rotate like it should, right? So those would be good associated impairments. Thomas test, good. Good. So those would be more the femoral one. Now, if we think back at the foot, right? Let's say we're looking at the foot. We watch someone squat. All right, we'll watch this person squat here, right? And their foot completely collapses, their arch collapses, right? In the moment, we want to know, you know what, if I fix this arch, is this going to change their pain, right? Because I don't want to spend 4 or 5 weeks teaching them how to do arch strengthening and working all their small arch muscles unless I think there's going to be a benefit to it, right? How many people out there have flat feet, right? It's pretty darn common, right? So we don't want to walk around thinking everyone with a poor arch needs. So let's control it. So based on maybe how big that person is, you can stick your hand underneath their arch, have them re-squat and check it. If you can't necessarily put your hand under there and have them squat for sake of maybe having your fingers crushed, you could always roll up a small towel and you can put a towel under there as well, right? Just under that arch and have them re-squat. And then you're just checking like, hey, does that change that knee pain when you squat? If it does, maybe we don't drive down this femoral rotation. Maybe we start looking more at the foot part. So then now, does that change your impairments that you'd want to test on the table? Right. So what would you want to look at now? So let's say they did a squat. It was more the foot, the pronation that you corrected that made them feel better. When you had them push their knees out, it didn't change much. So what impairments would you want to look at on the table? What would be your associated impairments?
Posterior tib strength, dorsiflexion range of motion.
What do we got, Cam?
We have posterior tib strength, dorsiflexion range of motion, plantar flexion strength. Can you hear me?
Nope, sorry. I put my volume down. Go ahead. Say it again. Sorry.
Dorsiflexion range of motion, posterior tib strength, plantar flexion MMT.
Nice. Perfect. Yeah. Right. So we want to look at arch muscle strength, right? If we're making them if we're improving their foot midfoot supination. What are the two big muscles that do that? Well, peroneus longus, post tib. Yeah. So definitely want to look at the strength of those, right? And then I think someone said plantar flexion strength as well. Yep. Right. It's a big rear foot inverter, supinator. You need that at the heel, right? So yeah, we want to work at strength. Did you throw out dorsiflexion range?
We sure did.
Yep, I totally agree, right? If someone doesn't have sagittal plane motion, so we think of dorsiflexion, sagittal plane, every time I do a squat, my tibia should be able to go forward, right? If I lack dorsiflexion, my tibia can't go forward in the sagittal plane, I'm going to start to compensate more in the transverse and frontal plane. So yeah, so someone may very much so turn their foot out and then pronate instead of just going straight forward in sagittal plane. But if I turn my foot out, that's going to definitely rotate my tibia. Now I have this knee rotation fault, which could lead to patellofemoral. So great. So the hard thing is, do you have time to check all of these things in your eval? No, right? I'm not going to be able to check the glute med, the glute max, the Thomas test, an Ober's test, step down, all these arch tests. So the idea is if we can pick something functional early, right? If you walk into the clinic knowing, hey, it's going to come down to one of these three movement faults. This is what research suggests. These are the most common reasons. You watch them do something functional, right? A squat, a step down, and you see, all right, where can I spend my time to correct? What should I try to correct in this moment? Good. So I think the last one we haven't talked about, right, in our...
Dr. LeMoine, we have a question. Yes, what do you mean by rotating the foot out?
So moving it into external rotation, right? If you turn the toes, so think of like if you're looking at the sole of my foot, if I turn my toes outward, kind of like a duck, right? Now it's a lot easier to roll through the middle of my foot into pronation versus my foot's here. I have to go through my metatarsals, which is how we should walk. Right? If I move this camera down, right? So ideally, my heel touches, I'll put it this way, my heel touches and I rock like that. That'd be ideal, right? This would be my arch, right? If I turn my foot out into external rotation, now when my heel hits, I roll more this way. So that's where we start to get a lot of these midfoot problems, people with bunions, because I never had to go into dorsiflexion. I never had to go this way into dorsiflexion. I just got to go into midfoot pronation, right? So it's not always the rotation coming from above at the femur. It could be the rotation coming below from the tibia. So think the next person that you see that was immobilized in the ankle. So whether it was some type of ankle fracture, or maybe a really bad sprain that they were immobilized for a couple of weeks, look at how they walk, right? Either A, they're going to take very, very short strides because they have no dorsiflexion, so they're not going to take a long step at all, or they're going to compensate by turning their foot out, right? I had a patient maybe about 4 months ago that sprained his ankle really bad, and didn't really do anything the first 3-4 days, did what he was supposed to. He kind of elevated it, iced it, and then he kind of got back to walking like he should. And when I saw him, I think I saw him like at a week and a half out. His ankle, his lateral ankle, wasn't really where he had pain anymore. It was still swollen, but he's like, his biggest pain was at his posterior tib. Like he'd given himself a tendonitis because with every step, he really was just loading his lengthened tendon, his post tib. But he was supporting his ankle. He was supporting his ligament. His ligament didn't bother him anymore after a week. But his biggest complaint wasn't even the ankle sprain. It was this new thing that he created himself. So it's a great compensation. Let me go back there. Okay, so if we were on physical exam, movement faults, the last one we talked about rotation from above. We talked about rotation from below. What about if it's right at the knee, right? Here, when we watch someone squat, we're calling it a quad dominant squat, or a knee hyperextension, meaning you have too much play in the sagittal plane. So, taking that down. So we watch them squat. We're looking for, does the knee go past the toe? Ideally, it should, right? We should allow our knees to go past our toe if I'm going to go bend over and pick something up. We shouldn't have this amazing, huge hip hinge if I'm going to pick up a pencil on the floor, right? However, if I was going to do that 3 sets of 15 in the gym and we're getting all this accessible and I'm going to have weights in my hand, we want to make sure that they understand that you should be able to squat without your knees going too far past your toes. I think the big jump has been people don't want the knees to go forward at all, and that's not correct. You have to get some of your weight anterior, otherwise you're going to fall backwards. and you're not going to be able to go down very far, right? So you should go into dorsiflexion, right? The idea though is when we do this, all right, let me replay that. So if I pause it there, right? If we look at how far past that is, I mean, she's quite a bit past. So if she was doing that just a one time to pick something up, totally fine. But if that's what she does when she does exercises, or maybe she has to pick up file cabinets all day long or files all day long at work and she's doing that 50 times, that's where we say, hey, you know what? You are loading your knee joint more than you are loading some of your hip muscles, right? There's a study that talks about the body weight triples on your knee, 3 times the body weight on onto your patellofemoral joint once your knee's past your toes. All right, so again, or granted, now you should be able to handle that load, but if someone has pain in their kneecap and their threshold and tolerance is lower, we can teach them to avoid that. Okay. Good. All right. Now on the flip side, maybe their knee isn't necessarily going too far anterior past their toes. Maybe it's when they're doing things functional, it's going the opposite direction. I'll try to pause that. Right extension. So look at her stance phase.
We have a quick question as well.
Now. So I'm not sure if you guys can see that or not, but you can see that she goes into a lot of hyperextension every time that she, right there, right? Every time she loads that leg, she's going into hyperextension. And so what does that do to the kneecap? You've now thrown your weight anterior to the patella, right? Your center of mass is anterior to the patella. So that's going to push the patella further back into the femur, right? So we start to think about, is it a sagittal plane problem where it's going too far anterior when I squat, maybe too far posterior during stance, right? How do we check to see if that's an issue? So someone's walking, they have knee pain, you see hyperextension. What can we do in the moment to see if that's kind of an issue and that's why they're getting their pain? Good. So Sam said check record bottom. Yep, definitely check it. See, if it's someone who we see it in gait, we probably expect them to have quite a bit of knee hyperextension on the table. All right. We ask if they can correct it. So if they can walk without going into hyperextension, does that change their pain? So that'd be a nice, easy fix. And the idea is you're just making them aware of this is what's driving it. Right? Manually assist. Good. Right. Sometimes it's hard to manually assist as they're walking. Right. It's a little cumbersome to be kind of on it. Maybe if you're on a rolling chair next to them, right? In the clinic, I'll put a big piece of tape, right? I'll do an X on the posterior knee in about 5 degrees of flexion. So that way they can't go into hyperextension when they walk, right? And then all of a sudden they realize, oh yeah, I can't hyperextend my knee. Well, does that change your pain? The answer is yes, I don't feel my knee pain anymore. Fantastic. Then we can say, all right, this is that may become a very valid treatment for you is I'm going to tape your knee. You can wear this for 2 to 3 days. You can shower with it. But it'll just give them the cues. Like every time you try to hyperextend your knee, you'll kind of feel the tape pulling on you and we can start to train you out of that, right? The idea though is why does someone hyperextend their knee, right? What do you guys think would be reasons to try to hyperextend their knee?
And Dr. LeMoine, we have a quick question.
Yep.
What would you prioritize for objective measurements in the initial exam? And I think you're kind of going over it by talking about the, looking for the impairment and then measuring it, but maybe you can go a little bit more and like kind of clean that up.
Yeah, definitely. I can clean it up. Let me finish this thought about this hyperextension thing and we'll do it.
We have tight hamstrings due to weakness. I'm trying to stabilize so they hyperextend. Weak quadriceps.
Good. Weak quads. Yeah. So think about it. If someone has to keep their knee flexed a little bit, they're loading their quad muscles. If they hyperextend their knee, right, their quads can turn off a little bit, right? So think of a stroke patient, right? Someone who has neurological weakness, right? They may hyperextend their knee every time they stand because they don't have the strength to load their knee without locking it out. So it's a way to get stability in that. So yeah. So at this point, on the table, right, we've talked about where we're going to look at their knee extension, their range, and we'll look at quad strength. Good. Can you think of maybe down the chain, what would be another reason why someone would, maybe when they squat, they would go too far anterior because their heels come up, or when they walk, their knee hyperextends.
All across the board, decreased dorsiflexion.
Awesome. Yeah, exactly, right? So we think about this lack of dorsiflexion, which is our primary saver for our knee in the sagittal plane, right? You think about in the sagittal plane, our talocrural joint has to move this way, it hits the ground first. If our talocrural can move in the sagittal plane nicely, it makes it a lot easier for the knee to do what it's supposed to do, right? They're teammates, right? If I lack dorsiflexion, you're going to have to compensate somewhere, right? We talked about compensating at the foot in the pronation, maybe with some rotation of the foot. Now you're going to have to compensate at the knee. Well, I'm going to have to go onto my toes too early, which puts my patella too far anterior in a squat, right? I can't let I don't have dorsiflexion when I walk, so now my knee has to stay back in the hyperextension, right? So it's a big one. It's a big impairment to look at. But again, we don't have time to look at all the impairments. So we always want to pick something functional that brings on their pain and start to make adjustments. So I think to answer that question, Chris, that someone threw out about how would we prioritize these, right? I'd say I have kind of there's like 3 parts to the objective exam. One, is this the right diagnosis, right? Do I have Patellofemoral, right? And that's pretty easy to rule in by pushing on the patella, right? Can I do a grind test? By ruling out the tibial femoral, I'm going to do active range. All right, you know what? I don't feel a big stiff end feel. It's not a mobility deficit for that, right? And in any competing diagnosis, I can kind of rule out pretty quickly. If I push on the patella or I push on the patellar tendon, is the tendon painful? If I do a contractile test, maybe to rule out, okay, so that's pretty straightforward. I should be able to do that within the first 3 to 4 minutes. I should be able to rule in the tissue, all right? Now, next is going to be like, you know what is a test that brings on their pain that I can make adjustments to and hopefully see some faults? And so on their side, that's going to be from whatever their ag was, right? So I'm hoping that it's an ag that I can change. So if they say it hurts while I'm running 3 miles, right? That's going to take longer. I'll have to put them on a treadmill, I'll have to do stuff. But if they're like, oh, it hurts when I squat, it hurts when I lunge, right? That kind of makes my eyes light up. So I'm like, oh, awesome. Let's look at it. I can look at that a couple times. We can change it. So you know what? Show me that squat. They show me a squat. I already know in my head, hey, it's going to probably be one of these 3 things. Is it A, right? Their knee is going to be too much in the sagittal plane. So the knee is hyperextended, or it's too far past the toes when they squat. Is it going to be too much of the femur rotation? Hey, you know what? The femur's diving into interrotation adduction. Or am I looking at the ankle and they're pronating too much, or they're going on their heels too early, or on their toes too early? And I want to look at the ankle. So really, I'm just kind of open to these 3 aspects. I'm like, you know what are they going to show me? Majority of the time, what do you think it is? If we had to prioritize, right, what do you think is the most common movement fault or the movement change we might make for someone with patellofemoral pain?
Femoral adduction IR movement fault.
Yep, exactly, right? I would say clinically that is probably 60% of it. As they come in, their knee dives in, right? And you think about, we already know this is way more common in females, right? Females have a larger Q angle. Females sit with their legs internally rotated, adducted way more often than men. So already, right, women don't have as much muscle mass in their legs to maybe control some of the movement faults. So unfortunately, they're set up a little bit more into having internal rotation already, right? It kind of fits with why they have a higher ratio of ACL tears sometimes, is because of that. So that's the most common one. And I'll do my correction. Can they correct it? I'll push their legs out. I'll tell them, I'll show them a mirror. If they can't, I'll put my hand on, I'll try to correct it. And if it makes their symptoms better, I'm now going to go down that route. So I'm not even going to worry about the ankle or foot at this time, because I was able to change their pain by changing their femur. So then now I'm going to get them on the table. I'll look at glute med strength. I'll look at glute max strength. I might look at TFL mobility, right? So an Ober's test. I'm like, all right, what do I need to work on to make you squat better, right? There's some people where you don't have to work on anything. Once you told them what the problem was, they had enough strength, they had enough coordination, they're able to correct it on their own, and their pain gets better, and they just got to practice that movement. Most people need some type of strengthening on the table or some type of strengthening before they can just start squatting automatically without pain. So that would be the most common one. The second most common one, what do you think that is? Right, so now instead of the femur, right, we're down to 2 left, right?
Lack of dorsiflexion.
Yeah, I would say looking at the foot would be the second most common one. So whether it's a lack of dorsiflexion or it's some type of foot pronation, tibial rotation, right? So I'd say, so the least common is actually addressing the knee, right? Like patellofemoral is like the best interregional dependent diagnosis we probably think of. Where it's like, oh, you have knee pain? We're not really gonna do much at your knee, right? We're gonna work on the above or the below, right? And your knee is just the victim in the middle. They keep talking about this victim of the knee on these 2 long bones. It's a big hinge joint, and it gets into problems when it has to do more than hinge, meaning rotate. So yeah, so whether it's lack of dorsiflexion or working on the pronation, whether we give them some type of arch support, we can tape their arch and have them walk and see, does taping their arch correct it? Does that change it? And we can work on it that way. Cool. Okay, good. So hopefully that kind of clarifies where I would go with my thinking. It's, do I have the diagnosis correct? What movement fault am I in? Based on that movement fault, it's going to lead to a couple of impairment tests on the table. Good. All right. We already talked about differential. All right. Associated impairments. We looked at hip muscle strengthening. We looked at arch muscle strengthening, right? And then we have another category in there that's kind of more looking at balance and proprioception. So maybe you have a higher level person that you've been working on strengthening, you've been working on stuff where now we're kind of training them back to sport. And we want to say, hey, you know what? You can squat on 2 legs really good. You have a good MMT, but we still want to work on more sports related stuff. And the nice thing is there's evidence related to a lot of these sports tests that say, if you don't score this well, you have a higher risk of injury, right? So not necessarily that every person needs to get this last component. It's more, what are their goals? What are they trying to get back to that you want to work on? So star excursion balance test, or like some of the hop testing. Okay. All right. So if we move on from our physical exam, because like I think when you guys said, that's a lot of things to test. So we don't test them all. You have to prioritize. But we go into intervention, right? Our intervention is going to be completely directed from our, oh, sorry. Did you say something, Cameron?
We have another question. Would you perform functional tests first and an exam as a guide to find your other impairments?
Yes. Yep. I would normally do my functional stuff first because it's in standing, and I try to do stuff standing before I get on the table. The reason I would maybe choose to do something on the table first would be if I'm not sure about my diagnosis. So if I'm not sure that it's patellofemoral and I think there might be something else going on, I might want to do some of those tests first to make sure that I'm okay to do these functional stuff. But normally, if there's no red flags, there's no other lumbar thing, they didn't mention numbness, tingling, back pain, their AGs match, then yeah, I'm going to start with, hey, stand up, let me look at your posture, look at something functional that hurts, can I change it? And then when I get into the table, I'll roll in my diagnosis and the impairments. Yeah. It's always easier that way because it makes your list smaller. If I think about, there's 35 impairments for the knee. If we think about mobility at the ankle, strength here, soft tissue flexion restrictions, you have all these impairments. How can I make that list 5, right? I don't want to check 35 things. I only want to check 5 things. So the sooner you can change something functionally to make them feel better, it then all of a sudden cuts off a bunch of things you need to test. All right, so we're under interventions now. And again, these interventions are going to be based on whatever path you went down with your patellofemoral patient. So if it's mobility, right, and you think that it's a patellar mobility issue, right? So I think someone talked about the J sign and some tracking signs. By all means, you can work on patellar mobility. I'd say most common, it's going to be in your post-op patients that were immobilized, right? So I think of my post-op ACL patients, right? I run an ACL class, and so I see many ACL patients every year. And they go through this point where everything kind of hurts because it's early on, things start to feel better. And then by about month 3, they start to develop patellar tendonitis, patellofemoral pain, because they're starting to do more squats and more lunges, and they're starting to load all this tissue. So it's really making sure, you know what, did you get all your patellar mobility back after being in that brace for a couple of weeks? All that swelling that's starting to kind of scar down a little bit, have we got it? So we think about, but in the general patellofemoral, the lady that runs 3 miles a couple times a week and has these big deviations, I don't find many mobility deficits in the patella. But, right, we work on gluteal muscle facilitation, right? We can work on IT band or TFL, right? So whether we're doing soft tissue, whether we're doing contract relax, whether we're doing PIRs, right? We're working on mobility of some of the drivers of internal rotation, right? The reason why we put facilitation under manual therapy is because for someone that doesn't know how to turn on their muscles well, we're not going to be able to strengthen them very well, right? So how would you know, what would be a sign of someone maybe having inhibition of their glute med or glute max? What have you guys seen in the clinic or that you've read about that would tell you, you know what, this person probably isn't going to do very well if I give them glute strengthening exercises? Good. Good. So atrophy, right? So we think atrophy is a sign of weakness, less muscle bulk, meaning less muscle power. Good. Trendelenburg. Good. Yep. So Trendelenburg definitely fits with the inability of that muscle to hold up the person's pelvis level when they stand on one leg. Good. So those all tell us kind of that there's some weakness, right? So how about if we say, okay, this person has weakness. If I'm going to give them a hip strengthening exercise, right? How do I know that I'm going to make that muscle stronger? There's often a common problem when we think about glute med and glute max with some of our, what would be considered normal glute strengthening exercises. How many of you have had a patient in the clinic that you've given them clams, and all of a sudden they're saying, yep, I feel it, I feel it, I feel it, and they point down to the lateral side of their thigh. You're like, oh man, I didn't realize their glute med went that far down, right? Or you're giving someone bridges, working on their glute max, and they're cramping, and you kind of have a little smile like, yeah, we're really working it, and they're grabbing their hamstring muscles, right? So really, it's very easy to compensate into hip abduction exercises or hip extension exercises because you have muscles that kind of do both. You have these synergistic muscles. So yeah, I think someone wrote, yeah, so are they feeling it in the correct place? Exactly. So if I give someone who has this femoral internal rotation problem and I'm trying to externally rotate and I'm working on exercises that externally rotate, I want to make sure I'm getting the right muscles to work. And one of the best ways to know that is it firing, right? So we can always palpate the muscle, right? When I palpate it, is it turning on, right? That's kind of part of clinical skills when we do MMTs, right? It's not really just about pushing the leg down. It's like, are they even using the right muscle? But then 2, if I have you do 10, 12, 20 reps, like where do you feel it at, right? If I go to the gym and do a bunch of bicep curls, I really hope I don't feel it in my upper trap the next day, right? I really hope I feel it in my bicep. That's kind of the goal. So often the reason why we have this in there is because the glutes have really strong compensation patterns. So you can use your try glute max and get hamstring. Glute med, it's often TFL or QL or lateral hamstring. So we have a category about just facilitating, just getting the person to work on these neuromuscular firing patterns, having them hold, making them aware of where the muscle is. Sometimes they need that first before we just go straight into strengthening, right? So that's kind of why that's in the mobility, right? Right. So if we move out of mobility to Therex, right, under coordination, right, now we have all these different exercises. But again, really it should fit into the category that you changed in the previous, in our objective exam, right? So I'm not going to spend time working on foot arch strengthening if I didn't correct their foot and make their foot change their pain. But if I did, if I corrected their foot and their pain got better with their squat, then I might be living in more of these short foot, working on doming, working on it in non-weight bearing to weight bearing to more sports specific stuff, really trying to keep the arch. Right? If I lived in the femoral adduction one, we already talked about the squat, the step down, right? We can work on gluteal strengthening, right? So let's say we're going to work on glute max, right? Maybe we need to work on facilitation. Maybe we need to work on just on the table, just pure strengthening, maybe with resistance. But then also we want to eventually get them to weight bearing, right? Most of these patients, when do they get their pain, right? It's with all these weight bearing exercises. So we eventually, if they know how to turn the muscle on properly, we can work on movement faults as well as strengthening at the same time. Right? So we can kind of wrap this band. They call this a Brugger's exercise. So it helps correct at the tibia, the femur, and then they can work on side steps. They can work on lunges, right? And the goal is every time they take a step sideways or forward, can they keep good femur position? Don't let the knee dive in. They're working hard below the knee. They're working hard above the knee. Good. Right. And the nice thing is with a lot of these, right, there's good evidence about using bands and hanging bands. If we click on it, right, it'll take you to the article to where a lot of these exercises are found. Let me go back a page. Good. All right. So, okay. So that would be kind of like our glute max progression. I know one of the questions we got through social media was about exercise progressions. And so the way that we have it set up here is kind of going from on the table to more resisted with bands to then more higher level. So here it's a great facilitation, working on clams, hip abduction, again, hitting Brugger's and standing. Granted, there's a lot of exercises for glutes out there. If you kind of look on in the studies, there's one study that looked at, they took the top 20 exercises for glute med, glute max, and then ranked them in order of EMG activity. And ones that had the highest, the lowest, ones that had the ratio to TFL and not. And yeah, so there's some good evidence out there on which ones you should be able to use to isolate. All right, so I think we're kind of getting close to finishing up here. Right, if we're under interventions, right, we've talked about our different things. Lastly would be kind of like we talked about earlier, going into some of these higher level jumping, some sliders, get a star excursion, working on those to say, hey, now that you have your strength, you have some good coordination, let's work on sports specific stuff. Right? And here you're looking at with the star excursion test, right? They have a couple of cutoffs, and one would be the anterior reach. So if she tests one side to the other side, there should be less than a 4 centimeter difference. So anything more than 4 centimeters, right, increases risk of injury. And then same thing with if you just measure all 3 directions. So anterior direction, posterior medial, and posterior lateral. If you measure all those compared to the other side, they should be within 94%, right? So you're kind of measurement things. So it's a great way to have some research behind, are they at risk when they go back to performance?
Dr. LeMoine, do you mind showing everybody again where they can access those PubMed articles for all the exercises?
Yeah. Let's see, which one did I click on? I click on it. So under gluteal strengthening, the glute max, I think I was under Brugger's, the one I showed, right? The first one I pulled up is, I think this one is a band one. They looked at different placements of bands and how it changes. Yeah. So at the bottom, I'll do that slower, right? So at the bottom of every page, right, it's going to have articles that kind of where we get that extra and what put us on. So these are all a bunch of articles related to femoral adduction, internal rotation, and using for this one specifically, you might see stuff more related to bands, to glute med, glute max stuff, improving femur rotation, because that's what this exercise is for. So yeah, so there, just click on it and it's a link, takes you there. If I do another one, let's see. And if I just do prone hip extension. Yeah, so here you kind of have a different muscle activation during a bunch of hip strengthening exercises, right? So here's a different one. Yeah, so they're on the bottom of pretty much every single video we have in here. If there's evidence behind it, we have articles linked to it. So for all of the manual skills, for all of the special tests, there's always an article linked to it. Okay, and then functional movement, we kind of already talked about hopping. If we think of the most common movement fault is this femoral internal rotation adduction, right? We're gonna work on strengthening. We're gonna work on teaching them not to let their leg dive in, right? How about, is there anything on the, maybe the lower side that we might wanna educate them about that could also correlate or correspond to this femoral adduction internal rotation? What do you guys think? Good. So someone talked about no sitting with legs crossed. Yeah, good job, Alyssa, right? If we're gonna spend 20 minutes a day on working them to externally rotate their legs, but then they're gonna go spend 8 hours a day internally rotating their legs, we're kind of working upstream, right? Is there another common position that people tend to fall into adduction internal rotation? Not necessarily exercise-wise, but just a common place where they spend a lot of time with their leg hanging over the other. Good job, Courtney. Sleeping, yeah. Especially our side sleepers, right? One leg falls down into the other leg. Our hips tend to be wider than our knees, so you're gonna hang out into this rotation. So we wanna make sure they have a good exercise routine, good movement knowledge, how to correct it. We wanna be their movement specialist. We also want them to tell, you know what, these two positions, sitting, sleeping, where you spend more time than anywhere else probably, can we make sure that you're not just hanging out collapsing? Even though they tend to not hurt people, there's no load on the knee at this point, but it still helps drive that movement fault. So we want to improve that as well. Good job, guys. Good. Okay. So that kind of takes us to interventions, right? Remember, there are outcome measures that we can use. So a LEFS or a COOS, the knee living scale, knee outcome survey living scale. So there's things that we can use as well to kind of track their progress. Good. So key impairments we talked about. Talk about that. Yeah, good. So that pretty much, in a nutshell, takes us through patellofemoral pain, right? Prevalence, clinical findings, physical exam. I'm looking at some of the comments now. I think someone asked about the article. Let's see, the article related to, yeah. So I don't know the name of the title, but there's two of them out there. There's one by a guy named Sarkowitz that he does a bunch of EMG on these exercises to see which one. And it's in JOSPT from maybe like 5 years ago. So JSPT, and if you just look at glute med EMG activity or glute max EMG activity, you'll be able to find that. I can look it up for you as well. I don't know the exact name of the title of it off the top of my head. Yeah. Anybody have any questions related to patellofemoral or knee pain or anything at all? Okay. So we are planning, so as I mentioned at the beginning, in case those that weren't there, that I have had a few people ask about a certificate of attendance, and we're working on that. If you're someone that needs one or wants one, just shoot me an email, right? Marshall@PhysioU.com. Shoot me an email so I kind of can link who I need to get it to, and then we will get one to that. Let's see, Sam, PRPS. What a history of sprain, strain, what's your email? Oh, so my email's at the bottom there, Laura. Yeah, so PRPS, I think with the very typical patellofemoral, where there's not signs of cartilage degeneration and cartilage wear, it's not needed. I think the cartilage under our patella, if it's still very much intact, it should be able to handle load a lot, right? Now, if someone has like a cartilage defect and there was some type of cartilage loss, then yes, they've shown to be very beneficial in doing these kind of injection stuff like that. But again, it's more with cartilage, a lot of cartilage generation, more so than like just typical patellofemoral tracking issues. I think, is that what you meant by that, Sam? Oh, can we do it? Or see, yeah, we can't, as physical therapists, we can't. But in ortho, depending on where you work, there's certain orthopedics that do it. I know in Los Angeles, there's a couple of places that you can pay out of pocket and have it done. The evidence isn't high with Patellofemoral to where it's like part of like typical insurance pay, at least not with the big company I work with. Yep. Let's see. Nice. So next one, oops, go back. So next one will be, again, next Friday at 9. It'll be the last of our knee ones. So we did knee OA, your mobility deficit, we did patellofemoral, and then we'll follow up with ligament sprains. So ACL, MCL, PCL, we'll kind of run through the ligament sprains with that. And then that will finish the knee, and then we'll move on to probably ankle and foot. Okay. Someone from New Zealand. Yes, that is very early for you, I bet. We are recording these as well, right? So if the timing doesn't necessarily work, we can definitely, we'll be following up with, say, Friday. Normally by Sunday, you'll get an email that that has a link to the recording as well as a link to the PhysioU site and everything that you guys will have access to. Unfortunately, I'll take blame. I kind of messed up on last one, where I hit recording, but then it stopped recording when I changed screens, and there's a little technical. So we don't have a recording of the second one we did, the knee OA. And I think we do have a recording of the first one, the frozen shoulder one. And so we can kind of maybe add a link to that one as well.
Dr. LeMoine, do you want to just quickly address Lauren's question, the sprains and strains kind of pertaining to what we talked about today? Could it be a contributing factor?
Sprains and strains, like at the knee, at the ankle? I'm not sure. What do you mean by that, Lauren?
Yeah.
History of sprains and strains in the knee. Yeah. I would agree. If someone has a history of a knee sprain, right, it means their knee might have a little less stability in their knee, meaning they might more likely have some rotation at the knee. Because that's the job of the ligaments, is to provide that stability. So based on how bad it was, they can have more likelihood to have some rotation and some play at the joint, which means more friction at the patella. On the flip side, I would say if someone has had a sprain enough where they've had to make adjustments to their stuff, where they've had to go through physical therapy, they've learned how to move properly, they don't let their knee dives in, actually they are a lower risk for patellofemoral. So even though they have more play in their knee maybe, and they have the history, but they've actually gone through movement training and glute strengthening and probably normalizing dorsiflexion. So there are other risks that are lower down on their list to make up for that. So they're probably at less of a risk. So I think it depends on how they manage that history of a knee sprain. Let's see. I want to make sure. So Sam, if I answer your question about the clostomine chondroitin, is it helpful? A new study just came out that that talks about glucosamine chondroitin. We used to think of it as being very helpful, especially in the knee. There's, out of any joint in the body, right, knee was the most beneficial, but it was only for min to moderate arthritic changes. So, and it wasn't until after, I think it was like 16 weeks. So you have to take this stuff for 4 months, have min to mod arthritic changes. If you have severe arthritic changes, it wasn't very helpful. So min to mod, and it's, but in this newer study just came out, they actually didn't find a difference versus the placebo group as far as changing function or pain and that. So maybe if you would ask me that question 3 years ago, I would have been like, yes, it's very helpful for the arthritic changes. But if we think of patellofemoral, where it's not necessarily cartilage degeneration, right? We think of it as more of like just rubbing and friction on the cartilage, where it's not necessarily completely worn down. Then we don't necessarily need to add that. But I guess if you're thinking of patellochondromalacia, where there are a lot of cartilage degeneration, then yeah, there has been some positive articles that show after a certain amount of time, consistently, so 16 weeks, I think, that it can help to improve pain and function and show it doesn't show more cartilage is growing, but it can strengthen the cartilage that's there to make it a little bit stronger going forward. But again, that would be the person that has evidence of these degeneration. But newer articles recently say that there hasn't been much of evidence to support that anymore. But let's see. Another question was, Lauren, yeah, in history. Yeah, so I think that kind of answers that part. Yeah, the more that you kind of already know on how to move properly and you have your impairments in line, it might actually be a benefit versus a hindrance. All right, so Sanjay asked, on average, how many sessions would you continue the same treatment for jumping ship, aka changing treatment interventions? You typically approach chronic pain the same way if a patient presented with patellofemoral pain, or you dedicate more time to education? Thank you. Great question, Sanjay. I would say based on the impairment I'm trying to work on. So let's say, for example, I pick dorsiflexion, and dorsiflexion is my primary impairment and they lack it. I'm going to work on it either A, until it makes changes. So let's say they're lacking 12 degrees and I get them back their 12 degrees. If I can do that in 1 or 2 visits and their pain doesn't change, I'm done already. Like, I'm not going to spend time on it because the impairment got better. So if the impairment gets better and their pain doesn't change, boom, I'm done, right? Now, if the impairment doesn't change, so I work on it for 2 visits and the impairment doesn't change and their pain doesn't change, I'll probably give it another 2 to 3 visits, but I'm going to change the way I do it. So if they lack 12 degrees of dorsiflexion, something made me think that if I can improve that, they'll get better. But after 2 visits, it hasn't changed. I'm not going to stop because I know ankles can be stubborn. I know mobility can be hard to change sometimes. So I may just switch up how I go about it. So maybe instead of grade 3s and 4s, I'm going to do grade 5s. Maybe instead of a bunch of 20-second holds, I'm going to say, you know what, you got to sit like this for 4 minutes, and I'll figure out ways to mix. We may change the dosage and the frequency and the program of how to improve dorsiflexion versus what we were doing. Now, if I do 4 or 5 visits and dorsiflexion hasn't changed, then that's where I'm going to really step back and make a choice. Either I got to go all in, and maybe we need to get this guy like a Dynasplint, right? Or I need to say, you know what? I've given it a good shot. It hasn't changed. I'm going to switch to a new impairment. So that's kind of how I would treat the mobility. If it's a strengthening program, right, we know that people don't necessarily get stronger immediately. So I may stick with that a little bit more until I show changes in strength. So if I have a handheld dynamometer and their glute med strength is 12 pounds and the other side's 20, all right, then like, all right, you know what, that's a 40% difference. I'm going to stick with this until I at least gain 20% back. So maybe I go from 12 to 16 or 17 pounds. And again, that may take me a couple of weeks. But as long as something made me pick that impairment, then I'm going to stick with it till the impairment changes. And then kind of going back, if it changes on, like, let's say 2 visits within a week, all of a sudden their quad or their glute test stronger, their knee isn't diving in as much, but their pain hasn't changed, then again, I'm done with that impairment. I'm not going to keep chasing it once the impairment changes if it hasn't changed their pain. Let's see, and the second part of your question was about chronic pain. Do you typically approach chronic pain the same way if a patient presents with patellofemoral pain? I would say I do if they have any movement faults. I'm still going to address them because there's still going to be some type of nociceptive driver. When we think of chronic pain or persistent pain, we think of there's some type of afferent, some type of input going into the nociceptive chain that's still going to be causing signals to go up to the brain stem, up to the brain. So I still want to address that. There's no reason, I don't want to just talk them through, keep squatting, it's okay if they look bad. But I would agree that there's going to be a lot of other centralized and peripheral sensitization that I need to address about it's safe to squat, it's safe if you feel pain. Every time you feel pain doesn't mean you're damaging your tissues, right? So there's going to be a lot more education, but there's still going to be this typical PT component. I'm still going to work on strengthening if they don't have the strength, because I can try to change it from both ends. I'll change the afferent coming in at the knee, and we'll definitely try to dampen the central going down as much as we can. And that's very personal to each patient about what they think is going on, what are their specifics, what are their belief systems, what are the stresses they have in life. That's not necessarily like as generic maybe as the physical therapy component to it. I hope that answers your question a little bit. Let's see. Any other questions that I missed, guys?
Dr. LeMoine, we had one question about the frozen shoulder webinar.
Yep.
If we have that recorded and if it's possible that they can receive that.
Yes. So in the email that goes out on Sunday, I think Dr. Wong, who was on that first one, he recorded that one, and then we can add it to this one that comes out. And I will do my best to hit record every time going forward. Good. And again,
Yeah, I think we had a question on. Oh, go ahead.
I was gonna say again, just shoot me instead of emailing me. I think some people have been putting their email in the chat box because the chat box is going to disappear. Email my PhysioU, Marshall at PhysioU. Email me there if you need a certificate of proof of attendance or something. Sorry, what did you say, Chris?
There was a question on Mcconnell taping.
Mm-hmm. Yep.
And like what is like the current research talk about it. So I was wondering if you can address that.
Yeah, the current research shows that it is very beneficial for pain inhibition. Like that's right. No long-term outcomes with it. You put the tape on. It used to be tape it one direction, and then it was tape it the other direction, and then it was whichever direction makes them feel better. And so I think the most current one was you pull lateral. So you start by pulling lateral, tape it down. If it makes them feel better, great. If it doesn't, pull medial. So it's kind of this little hierarchy. So really both can work. But the only benefit it shows is it allows someone to exercise to get stronger with less pain. So if the goal is, hey, here's your tape to wear while you go walk around, while you live life for a couple days, and you're trying to improve tracking, there's no studies that support that anymore. However, if when you squat, your pain's a 6, but then if you squat and you have with your knee taped and it's a 1, and squatting is what you're going to work on because you want to work on your glute max and you want to work on side steps, and it allows you to do that with less pain, by all means, why wouldn't we want patients to exercise with less pain? In the clinic, the way I do it is I'll test what's called the Mcconnell Test, where it's like testing knee extension. So they're seated at the edge of the table and they kick out like you're testing the quads. And then I'll check it at different angles. So 90, 60, 30, I'll find the angle that hurts, right? Based on where the patella is sitting in that groove for whatever is sensitive for them. And whatever angle hurts, I'll then add a medial glide, retest it, add a lateral glide, retest it, and then see which one makes them feel better. If I can't figure that out, if nothing hurts on the table, I'll do the exact same thing with a squat. Hey, squat down. When it hurts, okay, come back up. I'll add a medial glide, recheck your squat. Does that feel better or worse? Come back up, let me do a lateral glide. Does that feel better or worse? The one that makes them feel better, I may strap that on. But again, the evidence shows that it's really only in the time that the tape is on for pain, for improving pain, not necessarily long-term after that. They still got to exercise and get stronger. Good question, whoever asked that. That was, McConnell was very, very big, maybe like 10 years ago for the treatment of Patellofemoral. It was the thought was very much a patellar tracking problem, and the tape would improve the tracking over time, was kind of like the big thought behind that. And still used. I mean, I still tape, again, like I said, I tape people's patella to make them be able to exercise with less pain. Cool. All right, any other final questions? Thank you guys so much for joining.
Thanks, Joanna.
Yes, thanks, Chris and Cam for catching the chat part. Cool.
I'm just gonna say real quick for those who are still on. There are a bunch of resources that we're gonna continue to be posting on all the social media platforms. One new series is called the Teaching Table, and kind of what Dr. LeMoine addressed today, how to go through a subjective, how to go through an objective. There's a couple of videos on that, as well as, how do you program for a patient. So yeah, check those out. And it's, they're about 10 to 15 minutes, and they're going to go into really good detail on some of those specific topics.
Much shorter than these webinars. The idea is it's just
Mhm.
quick little, you're out for a walk, 7 to 10, 15 minutes.
Yeah, and if you guys have ideas of topics that you guys come across in the clinic, or things that you guys struggle with, that Dr. LeMoine can address, let us know. Get into contact with us, and we would love to kind of produce content for you.
Cool. Do you guys want to answer Gabriella's question, and I'll answer Sanjay's?
Yes, Gabriella, it's on Instagram currently. They will also be on YouTube. So right there on the shared screen that Dr. LeMoine has at PhysioU_, you just give us a follow, and that's where all the info has been produced thus far. And then Dr. LeMoine, we'll show you guys again that webinar, but last week he showed the first week he showed how to go into Knowledge Central. And he'll actually pull it up right now for you, Gabriella, so you can check that out. We also have multiple videos on the website that are within PhysioU.com.
So PhysioU.com, if you go to knowledge, all right, and so we have, right, anatomy series, mentoring minutes, sports health, product updates, the teaching table, right? So mentoring minutes are a bunch of 3 to 5 to 7 minute videos for social media. They're all based on, we pick an article or two for a condition, and we go over exercises, and we talk about that article and everything based on that article. The teaching table is our newest one. So here we go. All right, so our teaching table, and it's really, the goal is how do we bring the classroom to the clinic? So what are all those things that you guys learn in the classroom that now in the clinic that maybe we don't know, that harder to carry over? So yeah, so the follow-up visit, the irritable patient, I think we did subjective, the flow. So that's all kind of through there, but it's all through PhysioU.com and then knowledge. Cool. So good resource. Let me go back to this one. Good. Okay. Let's see. I looked at some of the teaching table videos, and it's hard to see the PowerPoint they present. Is it possible to get a better view of those? Thanks for that comment, Winnie. We can definitely talk about it. We filmed the first 6, so that definitely the first 6 we can't. but going forward, we can figure out a better way to maybe get those, or something to do with the PowerPoint. The PowerPoint's not, I think it's only like 2 or 3 slides. It's more of just like the topics I want to make sure I'm hitting as I answer questions from Cam and Chris and whatnot. But we can figure out a way to do that, definitely. Let's see. So Sanjay, if I go back to your kind of question, let's see, you had one about, the MMT, where you think it would have stumped you if you weren't able to reproduce their pain with your typical testing that maybe you would have learned in school. And how did I address times when I got stumped, which happened a lot early on, right? And I'd say the best thing is having someone that you can bounce ideas off of clinic-wide. So going through a residency and going through a fellowship, I was able to actually have someone dedicated 3 to 4 hours a week. So if there's someone where I couldn't figure out, either most of the common was everything hurt, so I didn't know what to do, or nothing hurt, so I didn't know what to do, right? Those ended up in mentor slots. So now I'm co-treating this patient with someone who's been a PT for 10 years and gone through residency fellowship. And so you start to pick up a lot of clinical pearls that they just don't have time to teach you in school, or because they never really made it into textbooks, because the textbooks would be so long if you put every single little new nuance in there. So I think having someone that you can talk to, bounce ideas off of, and say, hey, I had this patient, couldn't bring it on. And then people have lots of things that they can share with you. Another thing is just trying to really be open to being creative. I think that was one of my biggest things is, especially when it comes that time to assess these functional things, or even treatment wise, it doesn't always have to be something that you learned from a textbook or you learned from somebody. It's like, each patient's different. Each patient has their own ag, even though it may be the same diagnosis as the last person. Their impairments are different, their muscles are different, the way they move, their CNS is different. So always trying to make things a little bit individualized and having that in the back of my mind, like, all right, what is it that hurts with this guy? Do that for me. And so my asterisk sign may be different for every single person that comes in with a similar problem. And then starting just being open to that was a big thing that, and it took someone telling me that, being like, you don't need to be so rigid, right? PT is not black and white, right? We try to make it black and white with a lot of our evidence-based and our resources, but there's times where be open to adjusting things. So I hope that kind of makes sense. Yes, no, good job. Yeah, thank you, man. Great questions. That's cool. All right, I think we're good. All right, thank you guys. I appreciate everybody, and I will see you guys next week. All right.
Thanks, Dr. LeMoine. Thanks,
Yep,
Kim.
yep.
Thanks, Chris.
Hey, good. No worries, man. Take it easy, guys.
Later, food.
See ya, Fuji.